welcome to Project Recovery. I'm your host, Dr. Matt Woolley. Right over there on the boards is our good buddy Josh. And Project Recovery is brought to you by Reprieve Recovery Center of Utah, reprieverc.com up in Morgan, Utah. They are an all-female facility for substance abuse recovery. Do a wonderful job. Did you know, Josh, that recently the governor came out and said that Morgan County was the best county in Utah? Did you hear about that?
He's biased, though. He's also a rural guy.
Yeah. He didn't say that. I made that up. But I love Morgan. I
could have seen it.
I think he's thinking it though.
Yeah. Well, yeah. I don't know. He's from where?
Payson or something.
Yeah, something like
some
that.
place down south. We don't care. But up here in Utah, we love Morgan, and we love reprieverc.com. So check them out. Even if you're just interested in finding out about recovery centers and somebody in your life is looking into that, they'd be a great choice. Hey, so we're here. We're down a man.
Where's Casey?
So I'm going to brag, or I'm going to talk a little bit about Casey, maybe more than he'd like me to. But so Casey's working.
Is he working, or is he golfing?
No, he's actually working today, I think. And a lot of his work is golf, but he's working. And one of the things, so he wanted to come in today, and we tried to make it work, but it just didn't. So I'm running the show today. But Casey, he's talked in the past a lot about how his addiction and recovery process, created obviously loss of a driver's license, loss of jobs, and what a lot of people don't know is he still hustles quite a bit. So yeah, he's back on the air at KSL and he's doing this podcast, but surprise, surprise, those don't pay as well as you might think.
Whoa,
to run
spoilers.
a whole life on. So he has several jobs. I'm not going to name them all, but he has several and makes time for the podcast around those jobs, but wasn't able to today. So Casey, like a lot of people in recovery, are still hustling, but living a life in recovery is worth it, even if you have to hustle a little bit extra, I think. So, but today I thought, Josh, we'd talk about something that you're going to love. We're gonna run through a couple research articles before anybody turns it off. These are going to be interesting. Okay, these are exciting, interesting things, because the first one is about AI, artificial intelligence. Ooh, Josh just got the shivers.
It gets better from here.
Yeah, Josh loves it, man. But let's talk about this. So if you're not familiar, if you're a listener to this show and you want good information about what's going on in the world of research around drug abuse and recovery, the National Institute on Drug Abuse, which is a subsidiary of the National Institute on Health, is a great resource. Everything on the site is vetted and real research, not just people's opinions. So this information we're getting today is from nida.nih.gov. So that's a great place to go if you're interested in learning more about information on drug abuse and recovery. But this is an interesting study because this doctor, Brenda Curtis, utilized artificial intelligence, AI, language mapping software to be able to go in and take 2 years' worth of Facebook posts from their research participants prior to them going into a recovery center. And what they did is they used the AI program to cull the language that was being used in these posts for 2 years leading up to going into the center. And they looked at the context of what the words were and the context in which they were being used and predicted, it's predictive software, the likelihood of leaving treatment early. And that's something we talk about on the show a lot, is that, many people, I don't even know what the record is. I know we've had people that have been into treatment programs 13 times or more. Casey went once. Some people can do it once. But, leaving the program early happens quite a bit, or people that have to come back several times. So it's kind of interesting to say, like, who are the people? That was the question, is who wouldn't finish this program? Who would sign up for the program 30 days, 45 days, 90 days, and who would end up leaving early? How would we know that? Because, it's hard. The person themselves, they may not know that they would leave early, right? So they wanted to look at that. The AI program looked at, like, who do they talk to on Facebook? Is it friends and family? Are they talking about supportive things or non-supportive things? And they found these participants, mostly were men, that they used language, if they used language that referred to women in positive tones, which could indicate emotional support, left treatment less frequently than those who did not refer to women in positive tones. So that sounds weird because that doesn't really seem to have anything to do with recovery exactly, but it's the type of language that they were using. So again, men in the program who their AI program was able to identify 2 years worth of Facebook posts, and the ones who referred to women in more positive tones, positive language, they were less likely to leave the program. And they found that they could have predicted 79% of patients who did not finish the program.
That's a high number.
That's tremendous. You never get stuff like that in research. It's so rare. And they found that they could have predicted 79% of the people who left the program early, which was kind of crazy to me. That's a ton. And then this doctor has also done some other research. So that's kind of interesting. This other research, they utilized Twitter. And they wanted to look at language in Twitter and see what they could find from people's Twitter posts. And in this one, they found that the language analysis showed the language most predictive of opioid overdose. So now we're switching to a different study. We're not really looking at like people dropping out of recovery programs early. Now they're looking at something maybe a little more serious, opioid overdoses. The language analysis showed that language most predictive of opioid overdose was not explicitly about drug use, but was about physical and mental pain, boredom, and long work hours. Isn't that interesting? So people who had a couple years worth of Twitter, the program went through, looked at all of the posts that they had, and drug use and discussion wasn't actually very predictive of whether or not the people would overdose on opioids, but it was things like mental and physical pain, boredom, and long work hours, which kind of makes sense.
Yeah.
That what we're trying to do is we're getting down to more of a conscious level, maybe even, if you will, that like what is it that drives a person to use drugs, abuse drugs, maybe get in specifically to opioids. We know opioids are what? They're pain management medications. Originally was the intention, is that we give opioids for post-surgery and things like that. So it kind of makes sense that both physical, and I like the fact that they were able to predict mental pain, discussions about mental pain, so depression, anxiety, things like that. Boredom, and do you get bored easily, Josh?
No.
Yeah, I didn't think so. And I don't think I do either. Boredom, even when I was a kid, I always had stuff that I wanted to do, and I would say I was pretty busy. And as an adult, I typically am like, hey, when I'm done with this, I get to go do this other thing. So, but I talk to people all the time that boredom is actually painful for them.
Is that why you see, like, to get the amount of data to parse and then create predictive models off someone's Twitter feed, like that? That just takes so much data. Like, I'm sure there's got to be a correlation between boredom and someone's contributions to an online social media platform like Twitter. Like, for my Twitter, like, there's nothing there. Like, I can't imagine there being so much information on someone's feed that can create enough information that would generate predictive models. Yeah,
that's a great. I didn't pick up from this report whether or not they like how much data was required. They did. They did talk about like the thousands of people that they have in both of these studies. There are a lot of people in the studies, but it's interesting. And I don't, one mention of boredom obviously isn't going to mean you're going to overdose by opiates, but it was sort of that kind of all of those things. If mental and physical pain were being discussed, if boredom was being discussed, and long work hours. So I think what you have are exhausted people.
Yep.
Who don't have a lot of mental stimulation, like they're not enjoying what life is about for them. And they might actually be in physical pain, so there's the opioid prescription perhaps. And they definitely are in mental pain. And the mental pain was identified here as symptoms of depression, anxiety. So language that would indicate, this person is probably depressed, this person is probably struggling with a lot of anxiety.
That is so crazy.
And so, the inverse of that was also true. They found that people who didn't, they had a lot higher rates of protective factors that included conversations about wellness, travel, and fun activities. So sort of the exact opposite of the other was if people are discussing wellness, like people who might be discussing that they're meditating, they're exercising, they're going to yoga, they're doing wellness retreats, people who are talking about traveling. So that would be the opposite of boredom. They're planning ahead. And actually, one of the greatest things to get yourself out of depression is having things to look forward to.
Yeah, it makes me wonder what leads to someone feeling bored, because I think the more things you look forward to, the more like energy you have to spend looking forward to something else that isn't directly contributing to boredom. Like, I'm not sure. It's just...
Well, one of the things I do in therapy with, I see a lot of older kids and adolescents, young adults. Those are kind of the main population of people I work with, and teenagers will get bored. And I may have gotten bored of, I think everybody gets bored occasionally, but it wasn't a major problem for me as a kid. But for a lot of teenagers, it can be nowadays they'll just spend hours on screens, right? They're bored. They don't know what to do. They'll even say, I wish I had something else to do. I don't really like scrolling, or just going through countless YouTube videos, but that's what they're doing. Because when you're bored, it's actually hard to think clearly. Boredom is an interesting thing going on in your brain where your executive function isn't fully engaged. And so you're not really making great decisions. It's hard to get yourself out of boredom once you're bored. So one of the things we do with kids and with teens is in the office, we'll have them make lists of things that they really like to do, and it doesn't, preferably not all screen stuff. So like,
So not posting on Twitter about your depression?
Exactly.
Okay.
But I mean, get things they would like to do, like what's available to them. So, if they like to scooter or ride their skateboard or play sports or do arts and crafts, we make this list, and then they have to commit that when they're feeling bored, as soon as they realize they're bored, they just pick something off the list. And they always say, well, but at the time it doesn't, in the office it sounds good, but then when I'm bored it doesn't.
I was just going to ask
But
that.
if you'll force yourself to, because you have to remember, I remind them, this isn't Dr. Matt's list. This is your list. You made this. You made this
It's
list.
not your homework. It's the homework they gave themselves.
Exactly. And so you have to trust yourself that if you engage in one of these things, you'll kind of snap out of that boredom. And it usually works when we can get them to do it. The younger they are, the more I have parents kind of force the issue a little bit, like, oh, come on, let's do this.
Love.
And getting things available. So if it's, a kid with arts and crafts, you have let's get it out, put it someplace it's easily accessible. If you love to ride your bike, but the tires are flat, we got to get those pumped up, all that stuff so that you can just jump right on one of those activities and go. But boredom is a painful thing for a lot of people emotionally. It's and mentally kind of stressful. So, and long work hours, I get that because I'm trying now in my life to work less.
You're talking about Casey, you do a lot of stuff too.
I do a lot of
more
stuff.
than the average person.
I don't like to be bored. I interestingly enough, this morning, I was telling you before we started, I'm a clinical professor at the University of Utah. That's a little different than your typical tenure track professor who's teaching undergraduate classes and doing a lot of research. I'm in a health department. I'm in the Department of Psychiatry. And so my main job is seeing patients. I'm clinical. But I also do, teaching of medical residents, and I also am now helping with curriculum development for them, and then supervision of medical residents who are seeing therapy patients, and start trying to do a little bit of research and a few things. This podcast is in there for disseminating information to the public that's valued at the academic level. And we had my yearly review. I had to have my yearly review, which was actually great, and it was with the head of the child adolescent division of the Department of Psychiatry up at the U, and he's a good guy. Anyway, it's kind of interesting to be evaluated and have to go over. You have to sit down and answer all these questions about all those different areas of what you're doing, and it kind of keeps you accountable. But I do realize that over the years, I used to work like 70 to 80 hours a week.
Is that normal in your field?
I think for workaholics it is. I mean, there's never an end to work you could do, which is good. I remember when I was starting in college, and my uncle, who was kind of a big business guy in the world, and I was asking him like, "What do you do?" And he was saying, and I asked him, "Well, how much do you work?"
Yeah.
Because I know, like, I think I had just learned that 40 hours was like full time.
Yeah.
And he goes, "Oh, I don't keep track." And I said, "Well,
man.
why not?" And he goes, "It's depressing." And I said, "Well, how much do you think you work?" And he goes, "Probably 80, 100 hours a week."
Oh, my
He was a
gosh.
CEO of a big company. Anyway, I thought it was. I said to him like, "Oh, I can never do that." And he looked at me and he was very serious. He's a very fun guy, but he was serious for a moment. And he said, "Matt, I would much rather have too much work to do than not enough."
It's a great point.
And that has always stuck with me, that
great
I'm like,
point.
oh, it's sort of a fear. Like, what if I didn't have enough work to do? So, but now I'm trying to break it down to maybe just 55 to 60 hours a week.
That is crazy.
It feels like I'm on vacation now.
Okay.
But long work hours take a toll. And I think the type of work you do takes a toll. I mean, maybe, I don't know, the more physical your work, the more exhausting and the more likely you might want to be to use a substance to escape the stress, physical, emotional stress of that.
You're in that field of
Yeah.
having a day be mentally exhausting. From my perspective, you having to filter and process other people's emotions all day, that would leave me exhausted.
It can be if I have a long clinical day of a lot of patients. I enjoy it, but it can, that's, pretty much focused concentration the whole
Yeah.
time. But it's good work and I like it. But it's interesting. I've been a little hesitant about AI in my world because the way AI started off in medicine has been helpful for things like surgeons and other physicians who need a quick recap of what happened in a session. So they'll have, like, if you're post-surgical and your doc comes in and tells you everything that happened, the AI is listening, and the AI formats that into a note, and it can go right into your chart, and then the physician can look at it real quick and make any changes, and it's done like that instead of these. So that it allows doctors to see more patients. It maybe allows doctors to have a little bit better quality of life. But in psychotherapy notes, the experiments they've done with that, it's a little bit trickier, because what if in you're talking to a teenager who's just like, "Oh, I was so embarrassed, I wanted to kill myself."
Yeah.
AI can't really tell the difference between whether that's a serious
The
suicide
nuance and
threat.
the context.
Yeah,
Yeah.
and maybe it will someday, but right now I'm not a big fan of having AI in the therapy session.
That's a great point when analyzing how efficient it is at understanding context, because from that perspective, there's still so far to go. But conversely, to the first study where it just analyzed like the speech that the patient was using, that same speech could also be used for like introductory like analysis. So for like when patients first come into like an entry or for a treatment facility, that's where that context and nuance is less, I guess, depended upon. And I think that could be beneficial. So on one hand, AI is totally awesome and it's super cool and it like streamlines a lot of our workflows, but the context and the nuance is something that I don't know. I don't even know if like more work like gradually in the field can even pick up that, because
there's a human factor at that level, right? That's hard. And I agree with like an intake interview, AI would be great.
Yeah.
And that saves, because, when we're taking on a new patient, you have to go through their whole history and all of that. And it's a little tedious. It's important, but if you can streamline that process, that's really, really helpful. It's more concrete in a way. But when you're talking about different personalities in therapy, different ages, a 50-year-old man may be more likely to speak plainly about things than, a teenager, let alone like I am trying, but I don't really try to stay up on slang, all the new slang.
What's the last slang word you heard?
With Twitter or not Twitter, I guess, X, or it's, what do kids use? They don't use Twitter. Snapchat, things like that. What is the last one? Oh, that's a good question. I can't even think.
That would be such an interesting segment. I come in with like a word and you and Casey have to figure it out.
You know what? That would be fun. We could do that. I could start just keeping track of them when the teens pop them off in,
Oh, that's
in session, because sometimes I'll have to stop and be like, wait a second, what? And
that's a funny
it's
look.
kind of
Your
fun.
therapist is just like writing down, like not really what they're processing, but the words,
The slang that you're using. Yeah. So I don't know. AI is an interesting thing. I don't think it's going to be as apocalyptic as people like to make it out. We all grew up watching, the Terminator and stuff, so we have a different bias of fear towards
that's
AI.
true.
But I don't think it's going to be like that. But it's interesting, and I love this predictive language program that they're using. I think it's fascinating, and being able to use something like social media in a positive way, like if you would allow social media to, like, let's say you were entering a treatment facility that utilized this software, and you would give them access to your social media, and it could very quickly analyze, a couple years worth of your posts, and then come back with information like, hey, you're at high risk for leaving this program early. Let's try to, in the very beginning, get you on a different track and be helpful. Like, even if you knew that, because a lot of these people wouldn't even know that about themselves,
Right.
that they would be at risk for leaving early. So that's kind of interesting. And then also, again, how much people would have to, I think I get worried about people's privacy, especially as working in the medical field. I want to make sure that, everybody's privacy is there. And that gets trickier all the time, to be honest. But man, if we could predict opioid overdose for people, like if we could say, and it wouldn't be you're going to overdose, let's be clear, it would be you're at higher risk for opioid overdose. So maybe if you're going in for a surgery, you shouldn't rely on opiates in your recovery process.
That's the thing with AI. You could have a lot more specialized treatment for individuals, dependent on whether they specifically mention that in any type of interviews. Like, if you really think about it, like, obviously the information issue will always be an issue for AI, but imagine you are someone who's struggling with addiction. You reach out to a treatment center, they pull your information, like, with consent. By the time you go into that treatment center for an interview, they could already have created like a track for you. Like an individualized track for you based on all of your information, just like right then.
Isn't that amazing?
It's crazy.
And it could be done quickly, like within moments.
It's crazy.
And so I wonder if that'll be sort of a future focus for some of the more progressive treatment centers, if they'll be able to use some of that. And there isn't a ton of research on it yet, but it's the sort of research that's easy to do, and you can have tens of thousands of participants, because it's just data culling. You're just gathering data, so you just need people to, give you their permission to use it. My doctoral dissertation was data culling on personality disorder testing, and we just ran psychometrics on how the tests measure the same concepts. So I had hundreds of people in my study, and most of my colleagues, they were running actual patient studies, so they'd have like 30 people, if they were lucky.
Oh my gosh.
And it's very different statistics that you can utilize depending on the numbers that you have. And that's a great segue into study number 2, which had over 4 million patients in their study from around the world. This is nuts. Such a huge study. Very, very cool.
4 million is insane.
Also, a quality study published in JAMA, Journal of American Medical Association. So that's the real deal. And I said that like I was from Utah. It's a real deal.
I mean, you're Morgan and Shelley.
Yeah, Morgan. Well, I'm lucky I can speak English at all half the time. I love it. But they had 116,000 of those were people with diagnosed cannabis-related disorders. They were essentially daily pot smokers.
I like how you pick the 2 most controversial topics for research: AI and weed, or marijuana.
Yeah. Okay. Cannabis, right? So these people were either smoking it old school, or they were vaping it, right? This study we're going to talk about doesn't include edibles. But it's a lot. That's so many people that they were able to use from different areas around the world here in this study. And what they found was, and the reason I'm bringing it up is this is serious stuff, that people who have a cannabis-related disorder. So for the rest of us, we would just say pretty much daily cannabis users, either vaping or smoking, we're at much, much higher risk for head and neck cancers. Head and neck cancers, similar to people who smoke tobacco. Yeah, and that's flies in the face of what a lot of people have said over the last decade, is that, you know, it doesn't have the carcinogen potential that tobacco has. But for example, and this was one of the studies was in head and neck surgery, and so what they found is that the risk for specific cancers was higher in the group, including oral cancers and oropharyngeal cancers, laryngeal cancer. The findings suggest that cannabis use disorder is associated with an increased risk for head and neck cancers for adults who are chronic smokers. So, again, I believe it or not, even though I really discourage the use of marijuana for people, but that a lot of that you have to realize, I work with young people whose brains aren't fully developed, and we're finding out that while there are some benefits to THC in some ways with pain relief and some of those kinds of things, it's not risk-free. And one of the most dismaying things that I find is kids will come in, teenagers here in Salt Lake that go to some of the big high schools, and they'll say they all have teachers who really promote it, because obviously the teacher's smoking a lot, I'm assuming, and they're talking about like, oh, this is better, you know, there's no domestic violence, there's no DUI, you know, there aren't accidents, and it's just not true. There are a lot of social problems that come with it for people who are underdeveloped brains, because fully myelinated or developed brains, we're looking at your mid-20s, 24, 25 is about when that peaks out for people. And so you have an adolescent who's trying to develop the frontal lobes of their brain, and that's the last part of our brain, the most human part. That's our focus, concentration, executive function, problem solving, impulse control. That's why teenagers are so impulsive, is that part of their brain hasn't fully developed yet. And we do know that drinking and smoking weed and using other drugs delays that, or maybe even stops it from fully developing. So, I mean, there's a reason right there to not have teachers talking about that in schools, or other parents. I hear parents say, well, you know, it's probably not so bad. Well, it is for developing brains. And now here's another reason to not use it every day, is you're at much higher risk for head and neck cancers.
Well, that's so interesting. Why do you think, like, obviously marijuana has kind of, in my sphere, kind of taken over alcohol as far as daily use, well, obviously over daily alcohol use, but the idea of marijuana consumption is a lot more, the idea of using it is just a lot more lenient than when I was growing up. At what point do you think we have, like, become less educated on still, like, the dangers of
well, I think that
smoking and consuming?
The way it's been legalized around the country came out before the research really could catch up. And now that it's legal in most states in some degree or another, the research is finally catching up. Research takes a while. Good research, I should say, takes a while. It takes a decade or more for a lot of studies to start to validate certain ideas and things, or answer or questions that we have. And I think that that's part of it, is that we're just now catching up to it. The other part maybe goes back to what the other study was saying about opioid overdose, that, you know, mental, physical pain, boredom, and long work hours. People are stressed.
Right.
You know, people are stressed. We're overworked. We have a hard time finding value in life sometimes. As we get older, we naturally have more physical pain. For a lot of people, we naturally have more emotional pain as life becomes more complicated. You know, if you're raising kids and, you know, they're struggling, you're struggling with them. So I think that people have realized over generations that daily alcohol use is not a great way to deal with that, because of all the problems and intoxication and cancers and everything that comes with that. But I think they were hoping that, well, maybe I could smoke weed every day.
Right.
Like, that would be my escape. You know, it mellows me out, it makes me feel better. And it's kind of this quick fix that I think human beings naturally gravitate towards wanting a quick fix about things. So I don't blame us as a species for, wanting something that takes away mental, physical pain, helps us relax. But unfortunately, most good things take work. And so this is where I try to encourage my patients to get away from something like using weed regularly and doing things like mindfulness, meditation, yoga. Those kinds of things will also, and research is clear, shows that it can even reduce the need for pain medications for people with chronic pain. Definitely has been shown to do some good stuff for people who are anxious, depressed, stressed. I mean, mindfulness-based stress reduction, MBSR, is a whole field of study. This summer, speaking of my academic things that I do, I normally do a 4-week course for our psychiatry residents on child-adolescent cognitive behavioral therapy. We turned it into a 6-week course where we added mindfulness-based cognitive therapy for 2 extra weeks in there, talking about how we should be using mindfulness in cognitive therapy to help with depression and anxiety. And a lot of that mindfulness stuff, in fact, most of it, people can be doing and probably should be doing at home themselves. So, there are alternatives to managing our stress every day that don't have these kind of side effects, but they take practice, and they, like anything, it's not a quick fix, and it takes a little bit of time. Plus, I think people like being stoned.
I was going to say, in the back of my mind, I was trying to think about how, what would be the best way as a culture and a society to introduce alternative methods to pain management and stressful, stress from work. So in my mind, I was trying to think about what would be the most efficient way to introduce mindfulness and meditation to families and breathing practices. And I'm like, they don't care, man. They just want to be stoned.
Yeah, exactly.
It's so difficult.
Well, there's a whole culture around it, right?
Yeah,
music and movies and socializing.
So what you're saying is meditation and mindfulness isn't flashy.
It's not flashy. It's not as sexy as weed, I suppose.
Look, we should make shirts that says mindfulness is sexy.
Ooh, there you go. Project Recovery. Mindfulness is sexy.
I don't know how KSL is going to okay that, but yeah, we'll see.
We might have to sell it on the side.
Yeah.
Etsy. Well, there you go, man. That's it. A couple of research articles I thought were interesting. The AI stuff, I think I got interested enough in reading those that I think I'm going to make sort of a little bit of a study over the next few months of looking for AI-related articles that might have to do with my world of mental health,
love it,
substance abuse, things like that. And I might bring them on and talk about them. But I'm into this idea of using AI to predict and help people know what they're at risk for, whether it's leaving a treatment facility early or having a problem with opioid overdose, things like that. That's really helpful.
There's a lot of potential, and I'm not really familiar with the ins and outs of treatment centers. I don't know if there's a singular program that could be created to help a universal treatment center, but I would like to think that most treatment centers would look at a progressive system like AI and understand how awesome it can be. But
okay, I thought of this. I'll give this is your $1 million idea. You can have it.
Ooh, okay.
You ready?
You're going to tell me while we're recording the pod for someone to steal?
Yep.
Okay.
Because nobody's going to pull this off but you. But you would have a national database of just the AI predictive software program, and then different recovery centers around the country or world could get permission from their new patients to have you run their social media, and then you could send back to them personalized treatment plans. So that each facility wouldn't have to do it themselves. It could be sort of housed at National Institute of Health or something, or it could be a private thing as well. But anyway, there you go. You can pull that off. I can't pull that off.
Great.
I still have a hard time when I got the spinny beach ball on my screen. I don't really know what to do with that. So I'm not going to pull this off, but you might be able to.
Great. Thanks for giving me my $1 million idea on the pod where it's going to get stolen. Sweet.
You better get on it.
Appreciate it.
Get it done this weekend.
Oh, okay.
What else you got going on? You don't have anything. You don't have a girlfriend.
Whoa.
Come on.
Why
So
are
what are
you
you doing with your
doxing me on the pod?
Speaking of that, I got married.
You did get married.
Yeah.
Yeah, how was it?
It was awesome.
Am I going to have to cut this up and put it at the beginning?
No.
Oh,
no.
okay.
Well, I think we'll talk about it a little bit more
Yeah,
when Casey comes next time, because I think it would be fun to put some pictures. Casey was there, and he did the music. So, of course, we got married in Morgan because it's the most beautiful place in Utah.
Are we moving the pod to Morgan? Is that what's going to happen?
We're representing. And Casey was there. It was great. We had a wonderful day. Love being married. Love it. I do.
Yeah, you've got that new marriage glow.
Yeah, right. It's all about the person you're married to. And so I'm married to a wonderful person. And Casey came and did the music. We have some snaps of us together, so we'll maybe put those out on the social media where AI can tell us what they mean.
Gosh.
But that's it. That's it for the show today. Any final thoughts, Josh?
Nah, I love it. I love these kind of episodes because they're a lot more free-flowing, and we get to dive into a lot of the science, and that's my favorite part of this
me
pod.
and you, we like that, huh?
I love it.
Yeah.
And next week we'll
be back to regular shows with Casey on board.
And marriage talk.
And we'll talk a little bit about the wedding. I don't know what else there is to say other than it was fun.
No, I want the details.
Yeah, we'll give some details. You were invited.
I was invited.
You didn't come, though.
I did not.
Yeah,
no,
so you're going to have secondhand info now. I'll tell you all about it. Everybody got $1,000.
Oh, whoa.
Yeah,
that
if
was
they
not
showed
on
up.
my invitation.
Yeah, well, that's how we roll up there in Morgan. It's a big farm money.
I was up in Morgan like 2 weeks ago.
Were you? What were you doing?
Yeah, I was floating the river.
Oh, yeah, the Weber?
Yep.
Oh, man, we used to float that all the time as a kid. That was fun.
I floated it and fished it.
Yeah,
It
both.
was awesome.
Catch some good rainbows out of there.
Yep.
For sure. All right. Well, thanks for listening to Project Recovery. And join us next time with Casey and sort of a typical show. We'll look forward to seeing you then. And Josh, Project Recovery is what?
It's KSL Podcast.
Thanks, buddy.